So the next speaker is actually the chair of the session, and we are going to learn more about who really needs a biopsy, and if so, how many cores. Boris, it's a difficult task.
Thank you very much. Okay. I do have some conflicts of interest. I think these are not relevant, but it is relevant that I believe that in a few years from now, maybe we do not need an invasive biopsy anymore. So now I'm talking about biopsy, but I hope that we will not need the needle anymore in the future. So we discussed that prior to that, who do we need to screen for prostate cancer? What is our goal if we want to find prostate cancer? And this is one of the questions we asked before. And most of the panel said we want to find only clinically significant disease. And in the other group of the panel said, well, we have to take the patient into account. Some might be very worried even for low-risk disease. But the main goal should be, at least for me, to really focus on significant disease while reducing overdiagnosis as much as possible. So who needs a biopsy, in my opinion? The persons, I'm convinced by Virus data, people with a suspicious MRI, so Pirate scores 4 and 5, and with a 3, where the radiologist says, well, I don't know, I think we have to take PSA density into account. PSA density has the question, how do you measure it? As compared to TRUS, as compared to the MRI. Probably if you have the MRI, that's easy, but then which threshold? 0.15 or 0.2. This is something to discuss, but most of the panel said, well, not only 4 and 5, we need to take 3 and PSA density into account. DRE, digital rectal examination. Most of the panel says, well, yes, a urologist should do it. It provides valuable information. I doubt that. We do not use DRE anymore, and the German guidelines are now changing and say, do not use DRE for prostate cancer screening in asymptomatic men. We're talking here about who needs a biopsy, who is going to be diagnosed. So why do we say that? DRE is part of the PROBASE study. So in PROBASE, for the control arm, we offer DRE. But this is at present our current standard in Germany. But acceptance rates are poor. So many men say, well, no, I don't want that, I'm fine. And cancer detection rate in this population of young men, 45 years of age, was really, really, really poor. And if you compare detection rates in this young population in a screening setting with PSA, it's 1/5 only of the cancers that we find, and we have more false positives. So, and then we looked at MRI, and where did we find cancers? They should have been palpable, but it didn't work. So DRE is something we need to discuss. We don't use it anymore. Risk calculators. There are plenty of publications out, and I was happy to see our panel that in clinical practice, very few of us are really using it, because you could use risk calculators to spare MRI. You could use a risk calculator to then again spare biopsy after an MRI. They provide good data on paper, but in routine clinical practice, not many of the panel are using it. I think what is really important, and Vera already showed the data, if you have a good MRI and a good radiologist, do not biopsy patients with an unsuspicious MRI. This is one way to really reduce overdiagnosis, and we are getting prospective data that this approach is secure. My caveat is that we need to discuss a little bit later on, MRI really needs expert reading. Again, I'm showing the difficult stuff from the PROBASE study, but this is PROBASE are 4 centers in Germany, all university hospitals, and we assume they get good MRI. But if we compare our routine PROBASE reading to expert radiologists, 2 radiologists who read more than 10,000 MRIs, the increase in accuracy is enormous. So before that, you have a lot of Pirates 3, and you don't know, is the negative predictive value to really not biopsy a person good enough? If you have an expert, yes, that's the case. But do we all have experts? And what if we do screening on a big scale? This is something we really need to discuss a little bit later. Then the next question I was tasked is, if now I decided I want to do a biopsy, how do I do it? Do I do a systematic biopsy and MRI targeted? Do I do targeted only? Do I do target saturation or target and perilesional biopsy? What's the preference? And this is something I think is interesting. I'm again convinced and thankful that Jonas was here. If you do targeted biopsy only, you really decrease overdiagnosis. At the same time, you overlook some of the clinically significant cancers. They are small. There were only 3+4 in that cohort, but you do overlook a little bit. So the EAU guidelines currently say that you should combine targeted with perilesional biopsy, kind of like a target saturation. But if we do this, we run a small study, then again you increase overdetection. So it really should be a shared decision-making with the patient. Do we want to focus on significant disease? Or do we say, well, there is something on MRI and I really want to make sure that I find this disease? So this again is a question that we asked. And the panel still thinks that systematic biopsy remains important. So if you have biopsy indication, you really want to find out what it is, even if that increases overdiagnosis, because I think many of the panel feel comfortable doing active surveillance, but active surveillance in different countries, at least in Germany, we are not that good at doing really active surveillance. Yeah? 2/3 of men with low-risk disease get treated in Germany. That's poor. So then you did a bad job to the patient. So I think it's really a personal discussion with the patient. I think it's easy to say if there's suspicion on MRI, then you should do a biopsy, and then you discuss with the patient how much security you want. But I'm still questioning MRI expertise, and I want to tease that in the discussion. I'm happy to take questions afterwards, and I rely on you. I mean, this is really great people we have here. We will have 30 minutes of discussion later on. Ask questions, tease out. You really can find out what people are thinking here.